afternoon, everyone. It's really an honor to be here, and what a tour de force. I think Muhammad will change the clinical practice of hematology throughout the world. So it's really an impressive work, and I want to thank both Muhammad and Aaron for inviting me. I'll always come to Paris. So, so what I'll try to take you through in the next 20 minutes is taking you through a little bit of what has been done in Waldenstrom macroglobulinemia. And again, as Muhammad said and Aaron said, that we just had the IMW meeting a couple of days ago in Boston. So for those who couldn't come to Boston, I have some of the data that we've presented there just to update everyone. So these are my disclosures. And just to remind everyone, it was really so nice to see Gianpaolo Merlini receive the award this year because he trained with Jan Waldenstrom. And for those of you who don't know the history, Jan Waldenstrom described Waldenstrom macroglobulinemia by seeing a couple of cases that looked like myeloma. They had a high protein level, they had a monoclonal protein, but it looked different. They had lymphadenopathy. It was very viscous, the blood, so he considered it a hyperviscosity, and he found that most of those were IgM protein. And although they looked like myeloma, they behaved very differently. They started having neuropathy, cryoglobulinemia, and indeed, Bob Kyle and Gianpaolo Merlini tell you the story when he described those two cases, put it in writing because at that time it was still written, and then he posted it and mailed it, and he was thinking whether this would be accepted or not as a new disease entity. And he described many entities actually. Jan Waldenstrom had multiple descriptions of diseases, but Waldenstrom macroglobulinemia is one of the famous ones that are well known for him. So what is the diagnostic criteria? Waldenstrom is described by having lymphoplasmacytic cells in the bone marrow and an IgM protein in the blood. Now, many of us would start having the controversy or talking about the controversy of whether you should also describe it as having MYD88 positive mutation or not. Remember, 90% of patients with Waldenstrom have MYD88 positive mutation, while 10% are negative. And the 10% who are negative behave very differently, you'll see. They don't respond the same way, they don't behave the same way, and there's a discussion whether we should keep them in the Waldenstrom group or not. So again, you do not have to have the MYD88 L265P mutation, but it's one of those very significant criteria that we think of. Now, how do we diagnose patients with Waldenstrom? Remember that just like monoclonal gammopathies of other diseases as myeloma or amyloidosis, Waldenstrom, believe it or not, also can start with an IgM MGUS. And in fact, most of the IgM MGUS that we find in many of our patients will go on to develop Waldenstrom macroglobulinemia, and rarely do they develop myeloma or lymphoma or amyloidosis. And they go through a stage of smoldering Waldenstrom, which is not well defined, so we consider it an asymptomatic Waldenstrom disease, whether it's IgM MGUS or smoldering Waldenstrom. And then finally, you diagnose the patients when they have actual clinical manifestations. The most common reason we treat patients with Waldenstrom is anemia, believe it or not. It's not the hyperviscosity. Most of the patients will present, their first presentation is anemia, followed, of course, by the other things, hyperviscosity, which many of you will find it with headaches, nosebleeds and other things. And then as you can see here, many other things, lymphadenopathy and hepatosplenomegaly occur only in 20% of patients, so it's not very common. And the best thing about Waldenstrom is that it has this unique autoantibodies, so you can find Schnitzler syndrome, you can find the neuropathies with anti-MAG and anti-GM1 antibodies, you can have so many other interesting manifestations, the Bing-Neal syndrome. So it's interesting clinically to diagnose Waldenstrom and to find all of those entities and to figure out whether indeed this is all from Waldenstrom or not. Again, this is one of those diseases that now we need the genomic profiling, we need the actual mutation profiling clinically to make a difference. Not only because you will probably make a decision whether you treat this patient or not, so unlike myeloma where we say it's so complex and we have so many different mutations, yet we may not act on them, in Waldenstrom you actually act on the two mutations that are very common, MYD88 and CXCR4, and it can change your treatment decision based on that. So right now, at least at Dana-Farber, we have this available as a rapid heme panel, which is basically a targeted mutation panel, and we offer it for all the patients when we do a bone marrow biopsy. It can be done also on the peripheral blood. And that can help you indeed differentiate it from an IgM myeloma when you're not sure which one is which, or it can differentiate it from other things. So I think the description of the MYD88 mutation has really changed and revolutionized the way we think of Waldenstrom. And this was originally described by Steve Trion, my colleague, and many others, of course, as you can see here, described this. So it's really an international effort. Now the other one, and it's very close to my heart, is CXCR4 mutation. I've worked on CXCR4 for the last 15 years, so I was very excited to find it happening in Waldenstrom. It occurs only in 30% of the patients, and it's not one mutation. As you can see, the MYD88 was a point mutation of L265P. Here you can have multiple different mutations, so you need to sequence the whole CXCR4 gene because there are multiple different mutations that can occur in those patients. And as you can see here again, this was described by many people, and we can find it in about 20 to 30% of the patients. Now, why is this important? Because it confers resistance and higher proliferation rate. And we think that this happens later on as you have clonal evolution. So we have not seen CXCR4 mutation occur in MGUS. It happens later on in the patients, while MYD88 happens early on in the MGUS setting. So it's an early oncogenic event followed by potentially second hits with CXCR4 mutation. And here you see the signaling pathways downstream of those. And I think this is important as you start thinking of which therapy I'm going to use. So you can see that using CXCR4, you can go downstream to PI3 kinase, AKT, mTOR pathway, and ERK activation. And we know now that there are so many drugs in this area. Not only CXCR4 antibodies or monoclonal proteins or potentially small molecules that affect CXCR4, but downstream now we know there are so many drugs that affect either PI3K or AKT, or of course the MAP kinase pathway drugs. Now here you can see the other side is of course the regulation of BTK and how MYD88 signals through IRAK1 and then down to TRAF and NF-kappa B regulation, but also through BTK, and that's why we think ibrutinib is so important, and that's why ibrutinib works specifically in MYD88 positive patients. And this is another reason when you're wild type MYD88, when you don't have that mutation, those are the patients who do not respond to ibrutinib. So it's a very simple thing. If you are wild type MYD88, it may not be the best thing to give them ibrutinib, and you can start thinking of other options of therapy for those patients. So I'll show you one of the advances that we presented here or a couple of days ago in the meeting, and we've published it in GCO just a few months ago. And this is on trying to redefine asymptomatic Waldenstrom. Because we all talk about symptomatic disease, but when you see a patient with an IgM protein, whether they have 10% Waldenstrom cells in the bone marrow, 20%, 40%, you start thinking, is this going to progress rapidly to Waldenstrom? Should I start thinking of an early therapeutic intervention? Because the last thing you want is wait for them to have significant anemia, hyperviscosity coming into you for emergency plasmapheresis in the middle of the night. You want to try and predict of all of the asymptomatic patients, can I tell them what will happen to them? And I can tell you in clinic, at least at Dana-Farber, 60% of our patients are asymptomatic. We see them, we tell them, okay, come back in 3 months or 6 months or in a year. And you want to have a sense of how often to see those patients. And I can tell you the patients are the ones who ask for some better prediction of their prognosis, because the watch and wait is actually a watch and worry for most of our patients. They hate watch and wait. So one of the ideas that we have now is we started the whole clinic for prevention of progression at Dana-Farber, and I'd like to have collaborations with many of you. Can we refocus our effort instead of only focusing on symptomatic patients when it's too late, when it's already metastatic disease? Can we refocus on early symptoms and early signs when they have an IgM monoclonal protein but they're still asymptomatic? Can we define who will progress very rapidly, and can we treat them early to prevent further disease progression? And will that make a difference in the survival of patients? We started that in myeloma, and the biggest efforts we have are in myeloma, but we've also extended it in Waldenstrom because we think this can make a big difference. And you can be part of it through pCrowd. So pCrowd is the online, it's just like Muhammad is doing online education, we're doing online crowdsourcing for patients. So instead of crowdsourcing for money, we're asking every single patient who has an asymptomatic protein, whether it's MGUS, smoldering myeloma, smoldering Waldenstrom, to log on pCrowd.org. And you can look it up right now, Dana-Farber and pCrowd, and you can sign up or have all of your patients sign up. It's empowering patients because we do not ask the physicians to sign the consent. It's all about patients. They can sign up online, give us their clinical information and their samples, their blood samples, and we have over 4,000 patients who signed up, and we're now doing all of the sequencing based on that. So what about the clinical data? How can we identify patients? We went back to our Dana-Farber patients and looked back from 1992 to 2014 and identified 1,936 patients that we saw who were asymptomatic or who had an IgM protein at Dana-Farber Cancer Institute. And of those, we tried to remove all of the patients who were symptomatic, all of the patients who had AL amyloidosis, anyone who did not have a bone marrow biopsy, because we wanted to make sure we have a very significant cohort that's only asymptomatic and has a bone marrow biopsy. And we found a cohort of 439. Now remember, this is a huge number for Waldenstrom given how rare the disease is. And then we started looking at the variables. And what we said is we do not want to have variables that are dichotomized, because as you look at all the current criteria for MCAS and smoldering myeloma, it's 10% plasma cells, it's 3 grams, or it's 2 grams and 20%, and they're dichotomized. So if you have a patient who has 8% plasma cells or 11%, suddenly their diagnosis is very different. They have MCAS or they have smoldering myeloma. And we said, let's have continuous variables. Let's have truly what happens in the disease. The disease is continuous, so let's have variables that are continuous. And let's modernize things. Instead of you telling the patient, well, you have 2 grams and 10% and this and that, you have this diagnosis and this risk stratification, we offer you an online tool, and you can input the numbers of the patient at that time point, and you can tell them, oh, you fit the risk criteria of high risk or intermediate and low risk. And then you see them next time, and a year from now, you input the numbers again, and you can get new numbers. So this tool is available for everyone. We have it free for everyone, and in fact, the Spanish group has already indicated that they would like to implement it for all of their physicians. So how did that model came along? We found all of the criteria that indicate those patients who will progress to symptomatic disease, and we found IgM protein, bone marrow involvement, beta-2 microglobulin, and albumin were the 4 criteria, clinical criteria, that were most significant for risk stratification. And it truly defined for us a group of patients who are extremely high risk that will progress to Waldenstrom within 2 years, and likely those are the patients that we should consider some clinical trials for early therapeutic interventions. And then others that look like MCAS, you do not want to treat those patients, leave them alone, and do not interfere with them. It not only predicts for you who will progress to Waldenstrom, it also predicts for you to overall survival in general, and patients who had high risk were likely to have a worse survival. So again, early therapeutic interventions can make a difference in those patients. Now, to further confirm that this model really works, we went to the Mayo Clinic group and to the Greek group and asked them for their own cohorts so that we can validate it. So we had 2 external validation cohorts, as you can see here, and again, it validated very nicely between in most of the patients, especially if they're MYD88 positive. If they're MYD88 wild type, they do not respond very well. And then, of course, Dr. Thanos Demopoulos showed ibrutinib and rituximab combination in the upfront and relapse setting. So this is the upfront data, and it shows you a significant higher response compared to rituximab single agent. So rituximab was the standard of care. So adding to it ibrutinib and rituximab combination gives you that high response rate, which was expected, major responses, and definitely stopping that IgM flare from happening. And this is just showing you some of the adverse events as well as the progression-free survival in those patients. And you know very well ibrutinib with the AFib, with the hypertension that can happen in some of those patients. So again, making sure that you know, as well as risk of infections in many patients. I think the biggest question we have right now is, if you compare ibrutinib rituximab to rituximab, absolutely ibrutinib rituximab is better. But what if I have a patient who's 80 years old and I start thinking, do I give them ibrutinib single agent or do I give them ibrutinib rituximab? And we really don't know. We have not had a comparison, and I don't think we will, of ibrutinib alone versus ibrutinib rituximab. So I think it really depends on you and your patient discussion. It depends on the patient. Can they tolerate rituximab or not? I think combination of therapy in general makes sense. And potentially one of the questions we have is, if you give ibrutinib rituximab, can you avoid giving ibrutinib long-term, that continuous use of ibrutinib? Remember, in Waldenstrom patients, if you stop ibrutinib, the numbers increase significantly, the IgM goes back up. So maybe that combination can prevent that increase again, and maybe you would not need to have continuous use of ibrutinib long-term, again, because of all of the cost of therapy, because of the long-term toxicities. So we're looking at potentially stopping treatment in those patients early. Some of the trials that are ongoing throughout the world that you can see for newly diagnosed patients, there is DRC plus bortezomib, there is ibrutinib and rituximab versus DRC, and this is in the University College of London. What we are collaborating with, or we're working on in some of the studies, is looking at new ibrutinib-like drugs, so new BTK inhibitors, and that's including zanubrutinib, and you can see the comparison of zanubrutinib versus ibrutinib to look at toxicity profile as well as responses. And then, of course, which is the dearest thing to us, is a IST trial, so investigator-initiated trial of looking at ulocoplumab. This is a CXCR4 antibody from Bristol Myers Squibb that specifically targets CXCR4. We finished the trials in myeloma, and this is ongoing in Waldenstrom, combining ulocoplumab with ibrutinib in CXCR4 mutant patients. We're hoping that this truly would be precision medicine in Waldenstrom. And then, of course, because BCL2 is highly expressed in Waldenstrom and because of the apoptotic pathways, we're looking at venetoclax in combination with ibrutinib. So these are some of our Dana-Farber studies with novel combinations and novel agents in Waldenstrom macroglobulinemia. All right, so the last 2 minutes in relapsed refractory Waldenstrom, and again, this is more to open discussions for you. So we know the New England Journal of Medicine paper of ibrutinib single agent. This is how we got FDA approval, and it's the only drug FDA approved in Waldenstrom, ibrutinib, and this was published by Steve Trion in the New England Journal of Medicine a few years ago. And based on that, again, the phase 3 clinical trial, which was the only phase 3 showing ibrutinib and Rituxan versus Rituxan, presented by Thanos Demopoulos, again showed us the same data. So this was upfront as well as relapse setting. So this is some of the relapse setting data. Now, what is new and what's available now? Again, new BTK inhibitors. So acalabrutinib and as well as zanubrutinib are being used right now in Waldenstrom. And you can see here major responses, 80-90% response rate, very well tolerated. The question, of course, will be, do we replace ibrutinib or not? Do they have a better toxicity profile? And when do you use them if you've already used ibrutinib? So again, lots of data to be discussed about whether you use BTK inhibitors and whether you use from one BTK to the second, because if you've already used ibrutinib, as you can see here, the orange lines are people who had prior BTK inhibitors, and then they start using the second one, and whether you still have a major response or not. Most of them, as you can see, may not have as good or as a deep response, but they can still respond to therapy. So there's a lot of discussions of how are you resistant to ibrutinib, do you develop a mutation or not, and what to use in the future for those patients. So what are the current trials in the relapsed refractory setting? Again, there is a phase 3 trial, which we've talked about, but there is small phase 2 trials that we're working on. Ibrutinib and ulocoplumab, which I showed you, ibrutinib and daratumumab, again, a CD38 antibody that works very well in myeloma. We're testing it in Waldenstrom. Ibrutinib and ixazimib, which we've talked about in upfront setting as single agent. Can we bring it in the relapse setting? Trying to inhibit proteasome inhibition and BTK inhibition, and then other agents. And sorry, this is a mistake of the number 4. We don't have number 4 as a drug. So in conclusion, and I hope that I took you through truly a little bit of ideas from asymptomatic disease to symptomatic upfront and relapse setting. There's a lot that has been done in Waldenstrom. I think it's amazing that we have now precision medicine in Waldenstrom. We can actually look at the patient, decide, are they MYD88 mutant, are they CXCR4 mutant, and then discuss the different agents for them. I think we still need to get to that level of MRD negativity that we have in myeloma, and there's a lot to be done in the future. So with that, of course, I'd like to thank my wonderful lab and clinical teams, my collaborators from within and outside of Dana-Farber, our funders, Stand Up to Cancer, IACH, MMRF, Leukemia Lymphoma Society, and of course, our patients. Thank you.